Okay, well, thank you. Thanks, Melanie. Thanks to all of you. It's been just an incredible, several years since I've been working with Melanie and David in helping to put this on, and just learning so much and being able to interact with everybody. And I'm really very honored to be able to present during the 30th anniversary. Let me just try to angle this a little bit better. So, I'm a pediatric dermatologist. I'm a pediatrician and a dermatologist, and then a pediatric dermatologist. And so, what my talk is going to focus on is skin-related issues. So, a little bit of, what kind of issues can come up, what are some of the complications, what are some of the things that we might do to treat them, or maybe try to prevent some of the things that might come up. So a little bit about what we'll go over, just a little bit about capillary malformations, port wine birthmarks, terminology, eczema that can happen, cellulitis, skin breakdown, all things that are sort of chronic conditions that could arise at almost any time. A little bit about skin cancer and what the risks are, general skin care, and then one of my favorite topics, which is cosmetic camouflage. This is just a cartoon of the skin. So if and anybody, if you did a little biopsy of the skin, this is sort of a cartoon of what we would see. This is the top layer of skin, and this is kind of going down a little bit more. The top layers of skin, the middle layer of skin, and then the fatty area. And this is just showing blood vessels as they get smaller and smaller and smaller and reach the surface of the skin. And that helps us to understand a little bit more about what a capillary malformation is. And so I'm focusing in on that area there. That is where capillary malformation occurs, basically. So, capillaries are the connections between our veins and our arteries. And I really like this cartoon over here. If you look here, normal blood vessels go to normal skin. But then when you have dilated blood vessels or dilated capillaries or extra capillaries, that's when you can get a port wine stain or birthmark. So the terminology in general has been, pretty confusing over time. People like to use different terms. People really like to use hemangioma. I think we all know that, and it really is confusing as far as what it actually means. So what we know about, what we like to use, for a hemangioma is really this: a strawberry birthmark that is, really present in infancy and undergoes a very characteristic sort of growth and involution pattern. Versus a vascular malformation, which is an extra collection of blood vessels, basically. And then, what's the difference between capillary malformation and port wine birthmark? We use those really interchangeably. I think one way to think about it is that all port wine stains or birthmarks are capillary malformations, but not all capillary malformations are port wine stains or birthmarks. And there's probably a little bit of a continuum that we need to understand better. So capillary malformations, can be characteristically, they can be homogeneous, kind of like that picture on the left. It can also be a little more diffuse or reticulate, kind of like the picture on the right. And the same term has been used for both of those things, but you can see that the appearance is actually very different, and what it means may be very different. And then a little bit more extensively, you can see more of a homogeneous or geographic look on the left side and more of a diffuse or reticulate look on the right side, but can still involve a great portion of the body. So then CMTC is another term that's in this mix as well. CMTC refers to cutis marmorata telangiectatica congenita, which is also a kind of capillary malformation that has a very distinct appearance, and oftentimes, can mean different things in patients. And so you can see a really light-looking one on the leg here, and then a little bit coarser on the arm there. But you can see in general the surrounding skin is actually pretty normal. And in most people, that is the case, that the surrounding skin is pretty normal. But sometimes you can get atrophy underlying these areas of CMTC. You can also get erosions. You can see in this young woman, I don't know how well it shows up on the screen, but in here, those are areas of erosion that she had suffered early on. In general, treatment of these is not optimal. We can try some laser treatment. It can help with the erosions in some situations. Sometimes laser can actually make the erosions worse. So a lot of times capillary malformations, especially in KT and other overgrowth syndromes, can be not only capillary malformations but also have an underlying lymphatic component. And they're generally present at birth, the capillary malformations. It's actually in isolation, it's the most common congenital vascular malformation, and depending on which source, it can be in up to 0.5% of people. It can occur anywhere in the body, and in people that don't have underlying or associated problems, the most common location you're going to find them is the head and neck. So sometimes, in some people, they never cause any problems. It's really a cosmetic physical appearance. But certainly, especially in people with KT, they can cause you problems. It can get thickened, it can have blebbing, and this happens generally over time. So about 2 out of 3 may have thickening by their mid-40s, and 1 in 4 may have blebbing by their 40s. And when we see that blebbing, it's most commonly due to an underlying lymphatic component. So here's a photograph of just a capillary malformation on the chest, and you can see these small little blebs. And so the size of blebs can definitely really range. Usually start out fairly small, but can increase in size over time. You can see these blebs too. So the picture on the left is a little more discrete. You get these little blebs here and there, but the picture on the right, the blebbing is nearly confluent. You can imagine that that can be pretty challenging to take care of. It can bleed, it can break down, it can hurt, it can lead to infection. And then you can see these small little ones on the trunk as well. And so over time, certainly these problems can occur. So right at birth, you might not have any problems. So you can see the same child at birth on the left, a very homogeneous, localized capillary malformation. You can already see the veins that are radiating around it, and then you can see just at 6 years. So for him, it didn't wait until his 40s, but you can see the blebbing that's occurred within there. And for him, this is really challenging because it bleeds a lot, and when it bleeds, it hurts. It also gets his clothes dirty. And then here's another young person who had this. You can see some blebs already, and then you can see just 4 years later the amount of thickening and the increase in the blebs. So those are common. I think we're all fairly familiar with that, with the thickening and the blebbing that can occur. But what other things can go wrong with a port wine stain? There are several things. So dermatitis or inflammation of the skin happens actually not that uncommonly. You can get growths called a pyogenic granuloma that we'll talk about, and then we can certainly have complications that are related to treatment. So port wine stains are susceptible to overlying dermatitis. You're more likely to get dermatitis in that area than you are in skin that's not affected with a port wine stain. You might not get eczema or rashes anywhere else, but you can get it really localized to the capillary malformation. It can be really itchy, and the things that we usually do to fight that is to keep it really well moisturized. Vaseline or petroleum jelly is a fantastic moisturizer. It provides a really good barrier also. So a lot of times if you're subconsciously going to scratch, you'll feel that greasiness and it'll kind of draw your fingers away from it. Sometimes, despite moisturization, we might need to use topical steroids depending on the location. We can do a low strength, we can do a high strength, depending on the location. So in this person, it's on the eyelid. We wouldn't want to use a topical steroid, but there are some steroid-sparing medications we can also use. Port wine, birthmarks, and capillary malformations are also susceptible to allergic contact dermatitis. So we're really careful about what we're putting on there, and other than moisturizer and that sort of thing, we're careful about what kind of adhesive comes into contact with it, what kind of dressings we're using, because you certainly may develop an allergy to some of the glues in those adhesives. You can see here on the leg that person's really itchy. They're really kind of going after that dermatitis there, and if it keeps going, it could get infected, which could lead to bigger problems. So we really try to knock it out and stop it right there if we can. So pyogenic granulomas are also vascular growths. They're a little bit different. They can occur spontaneously just in sort of the general population, but and they can be a response to trauma or to some sort of intervention or treatment. And they seem to be a little bit more common in pregnancy. They're really very friable, so they like to bleed. And in dermatology, we call this the Band-Aid sign. So if someone comes in with a Band-Aid over it, that's gonna, the chances are it's gonna be a pyogenic granuloma. So here within a capillary malformation, you can see a couple of these discrete growths. They're friable, they're bleeding, and fairly consistent with a pyogenic granuloma. We do always, when we remove these, we usually do send it to be looked at for histopathology, because there are some, rarely there are some skin cancers like melanoma that can mimic a pyogenic granuloma. So we want to make sure we're dealing with what we think we are. It can have this kind of appearance too. So a couple of earlier pictures I showed you is a more classic appearance, but it can also sometimes look like a little sack of grapes or a few grapes strung together. This is actually a baby who had a congenital hemangioma, and within it he developed this pyogenic granuloma that bled a lot. So what do we do for these? Usually the mainstay is just surgical excision. So we numb it up. We usually shave it off, and then we kind of cauterize the base to try to prevent it from coming back and to stop the bleeding. Other things can be done short of that. So depending on the size and the location, we can sometimes use a laser to treat these. Topical medications have been used with some variable success. So imiquimod and timolol are two medications that have been used. I'm a little bit cautious about using these within capillary malformations, because we talked about how they're prone to dermatitis and irritation, and some of these medications can actually be fairly irritating, particularly imiquimod. So one question is, can we predict who's going to have problems just based on the appearance of the capillary malformation? We may be able to, depending on the characteristic of the malformation, is it geographic and sort of homogeneous, or is it more widespread? So this is one, that's more geographic and a bit more classic. And then another geographic on the left, that baby that we saw. And then this picture on the right is a little bit blurry. I apologize for that, but that's a little bit more of a blotchy. So this was a study from a while ago that looked at this comparison, geographic versus blotchy stains, and what they found is that with geographic ones, you're more likely to have complications, you're more likely to have associated underlying lymphatic malformation, you're more likely to get cellulitis, to have pain, to have problems with bleeding, and probably also more likely to have blooding. So you can see this one's a little bit more of a blotchy one, a little more widespread. And so these patchy, or also sometimes called reticulate, or also called diffuse capillary malformations, overall carry a really good prognosis. Usually you don't find problems with cellulitis, with blood clotting. You can have some overgrowth with this, but it's usually fairly mild, and it's usually not progressive. All right, so I want to talk a little bit about treatment of port wine stains or capillary malformations. Our mainstay of treatment in general is using this type of laser called the pulsed dye laser. The goal of it is to lighten the capillary malformation, and what it does is it targets hemoglobin, which is in red blood cells. And so the idea is it targets these red blood cells, but it really doesn't do too much damage to the surrounding tissue. And so out of all the lasers that we have sort of in our toolbox for this, it's one of the safest. It can also be used to treat the thickening. Sometimes if we treat, there's some belief that sometimes if we treat earlier, we might be able to prevent thickening later in life. And usually it does take multiple treatments, anywhere from 1 to 2 months apart. It can take several, even up to 10 or 12 at a time. And then oftentimes after we reach a desired effect, we usually have to retreat again several years later. So maybe about every 5 years, there's a little bit of maintenance involved. So one question always is when to treat, and that's a hard one to answer. In general, when it's in a cosmetically visible place, many people want to treat. It also depends on how motivated the person is. So, we probably want to stay away from doing recurrent episodes of anesthesia for a young baby that might not necessarily care. But when someone's older, they may be able to say, hey, I'm really motivated to have this treated, so I can use some topical numbing cream and I can get through this. And then who should do the treatment? It really should be someone that's experienced with this laser, that has a lot of experience with not only capillary malformations, but also in the setting of other problems like KT and overgrowth. And usually that'll be a dermatologist or plastic surgeon, but there are others that can use this regularly and safely as well. Are we able to predict who's more likely to respond? We definitely can. And so the darker your skin, the less likely you are to respond, and also the slightly higher your risk of complication from the treatment. When you're treating a capillary malformation that's not on the face or neck, you tend to get a little bit less response. And so in general, I say when I'm treating on the face and the neck, we can aim for about 90% improvement. But when we have a non-face or neck location, then it's usually somewhere, hopefully, ideally around 50% improvement, and that's in the percentage of lightening. So you can see this is this is on the face and the neck, which is an optimal location, and after 3 treatments, that's the result on the right there. So what kind of complications can you get from this pulsed dye laser? Well, in the short term, it can be painful. You can get some blistering or crusting if the energy is a little bit too high. You can get burning or bruising, and that bruising can last some time. And if after laser, I always say to keep this area really well protected from the sun, because if you get a little sun onto it, it can cause a little reaction that causes some pigmentary changes in that bruising. In the long run, you can get permanent pigment changes, usually if the energy is a little high, or if you have a little bit darker skin, sometimes you're more susceptible to that, and you can get a little bit of scarring too. So sometimes, as in this situation, the pulse dye laser is really not going to be enough. It's really good at thinner capillary malformations, smaller blebs, but when you get a lot more involvement, a lot more thickening, it's usually not going to be the answer. So then what else do we have available? There are other lasers. There are a whole variety of lasers, and all of them have a little bit of a different wavelength that they use, and thus a little bit of a different target. So there's the Nd:YAG laser and the CO2 laser that can be used. There's a couple of other ones. There's something called photodynamic therapy. And then is there a role for sirolimus? The picture on the right I showed is one of the original reports of using sirolimus on the skin topically, and this is in a condition called tuberous sclerosis. And you can see the improvement from the top picture versus the bottom picture. So is there a role for this in our situation? And so there's been a little bit of study into this use. So this is looking at sirolimus in Sturge-Weber syndrome. And what they did in this study was divide each person's face into 4 quadrants. And so one quadrant had sirolimus and laser, the other quadrant had just topical sirolimus, the other quadrant had just laser, and the other quadrant had nothing. And what they found at the end of this study is that the quadrant that had both did the best. Now there are some limitations to this. I don't think we can conclude from this that this is the way to go, because the quadrant that they did both in is in an area of the face, so more laterally to the side, that tends to respond a little bit better to laser anyway. And so this might be an ideal situation, to try this in. This person has these cutaneous blebs, small little lymphatic malformations, has a lot of dermatitis. And so a combination of laser and topical sirolimus might be a good modality for this person. Okay, just a little bit about venous and venal lymphatic malformations. In general, venous malformations don't cause a lot of problem on the skin. They're often visible on the skin as a kind of a blue mass that's just under the surface of the skin. You can have lymphatic or lymph vessels kind of as a part of it quite often. And it may form a little mass or a clump that you can even see visibly just underneath the surface of the skin. They can have some associated overlying telangiectasias as well. So you can see pictures here, kind of some more typical venous malformations of what we might see on the surface of the skin. But sometimes, when they're like this, they can be associated with other problems, swelling and skin breakdown, and certainly pain. And then lymphatic malformations, I think these are really atypical and special on the skin. You can see these small little areas. We like to call this frog spawn that you see down on the bottom right there. And so it's often really quite clear, but you can get blood within it, so it can have hemorrhage. And this can really be just the tip of the iceberg. So like in the top left picture, this really was the tip of the iceberg in this young man. He had a lot, he had a lot of other problems, but he had a lot of underlying lymphatic malformation. Whereas on the bottom right, this person just primarily had cutaneous involvement, so just skin involvement. And then you can see here, this is sort of a little bit of the tip of the iceberg too. This is more of a typical scenario that we might encounter. And so in the top area and the bottom area there, you can see that there's bleeding. So another situation where maybe a combination of laser and maybe topical sirolimus would be beneficial. The jury's kind of out on that. And then of course, there you can encounter this situation where the lymphatic malformation is just thick and large and bleeds and oozes and is painful and leads to infection. So what else can happen? So of course superficial thrombophlebitis can happen in up to 15%, which is just inflammation of the superficial veins, primarily on the leg. Treatment for that is usually very supportive. In general, most will self-resolve within a couple of weeks, so with compression and elevation and some ibuprofen pain medication, most people can get better. There are situations where that doesn't happen. It's recurrent, it's much more painful, and in those scenarios, we might need to consider some of the other things we'll hear about today. So dermatitis can be related to venous malformations too, and that often ends up being stasis related or lymphedema related. So when you have so much swelling down on especially on the legs, that really sets you up for inflammation, dermatitis. And you can see on the right-sided picture, there's discoloration also. And so that's red blood cells that just hang out in the top layer of skin and cause that color change. So dermatitis in that scenario is also, very similar. We like to moisturize. We like to use topical steroids. Elevation and compression are always really good in trying to help prevent fluid-related dermatitis. It is really important for us to treat this, to recognize it, to treat it early and effectively, because if it keeps going on, it can really lead to ulceration. And once you get to ulceration, it can be really hard to heal that. It can also lead to infection or cellulitis. I was putting this about compression pearls. I won't talk about it too much because we're in for a great lecture by Dr. DePompolo, but pearls that I've learned from working with Dr. DePompolo and his team is that proper fit and coverage are so important. There are areas that we can pad to help it, a little bit more comfortable, overlying malformations that might stick out a little bit more with foam or a lamb's wool. And that a common mistake is too much pressure, not too little pressure. So cellulitis, the areas that are prone to cellulitis are really these areas where fluid likes to hang out, where you get dermatitis, where you get a lot of fluid overload. And when it pools in that area, the skin integrity is not quite as good as it is in places you might not, or you don't have all of that fluid. And when you have skin integrity that's not that great, it leads to little breaks in the skin where bacteria like to enter and then cause cellulitis. So hallmarks of cellulitis are redness, warmth, and pain. And I think we find that many of our patients are really good at recognizing their own cellulitis. And this is just examples of what cellulitis might look like. And treatment is usually antibiotics, often by mouth, and we'll often give a prescription for standing antibiotics so that as soon as the signs of cellulitis come on, those can be taken and avoiding a much larger problem. And this is another situation where rest and elevation can help. So one question is, can cellulitis be prevented? Well, there are things that we can do to minimize our risk of getting it. So good skincare, which we'll talk about a little bit later, but washing daily, doing bleach beds can be helpful, which I'll talk about as well. Compression. Treating athlete's foot is really important because athlete's foot leads to little breaks between the toes where bacteria like to enter. So being cognizant of that is really important. And then again, is there a role for topical sirolimus, especially if you're getting leakage over a cutaneous lymphatic malformation, and that's really what's predisposing you to infection. So this is like in this young man, he was getting lots of infections. I was landing him in the hospital, primarily because of this source, so a lot of bleeding and breakdown, and so a combination of laser and topical sirolimus was actually did really, really well for him. Ulcers are a huge problem, I think, not only in KT vascular malformations, but in general. But they can be seen a little more commonly with malformations, leading to that impaired skin integrity. A lot of times, post-procedurally, if we do something, we make an ulcer, that skin is already impaired in its ability to heal itself, and so then it becomes even harder to heal itself. So we really do think long and hard before doing something in an area where there's a lot of swelling and stasis, because it might be harder to heal up that wound. So there's a kind of common start of an ulcer. And then treating them, really very challenging. People, make their entire careers based on treating ulcers, and so compression is very important. Good skin care is very important with cleansing, protecting the area. Vaseline and gauze, or Vaseline gauze is one modality. There's so many good wound care options out there. Antibiotics if they're infected. We'll sometimes use whirlpool therapy, which leads to a little bit of gentle debriding, which can help. We can put a little bit of antiseptic solution in this whirlpool that can help as well. And then in some situations, hyperbaric oxygen might be necessary to heal a long-standing ulcer. Just a few minutes about skin cancer. This is certainly not very common, but there have been a few reported cases within malformations, and several as a complication of ulceration. It's pretty rare to have a spontaneous skin cancer develop like within a capillary malformation or another malformation. But squamous cell carcinoma is the one that we're going to be most interested in and the most concerned about. So when you have a long-standing ulcer in particular, that puts you at a little bit of a higher risk of developing a squamous cell skin cancer. This is a little bit of a challenging scenario because if you have a long-standing ulcer, the last thing I want to do is biopsy it because it's probably going to make the ulcer worse. So we really have to have a high index of suspicion about any changes that might herald a worrisome skin cancer development. It might require multiple biopsies, and usually these are treated with surgery. You can tell this is a really old picture, so this is really rare. So there has been the rare report of spontaneously a basal cell skin cancer developing within a capillary malformation. Now this is an area that basal cells like to develop, so is it coincidental? We don't know, but it has been reported. And then I put this in there because there's been one recently published case of an angiosarcoma, which is a really rare cancer of the blood vessel lining that has developed in one person with KT. But again, this is just extremely rare, and we would have a high index of suspicion to think about this. All right, in the last few minutes, I don't want to take too long because I don't want to take away from the others, but what is good routine skincare? Bathing daily if possible, using a gentle soap. The harsher the soap, the worse skin can react. So a lot of times with teenage boys, I have to stop them from using things like Irish Spring and Axe and those sorts of things that are really well scented. Moisturizing daily is important. Like we talked about, treating the first sign of athlete's foot, treating any dermatitis very actively. I say don't wait until it gets bad enough that you need topical steroids. Treat it proactively. Bleach baths, if you're predisposed to infection, can be really helpful. And the recipe, it's really dilute. People look at me funny when I suggest it, but it's really dilute. It's sort of like swimming pool water, so it's just half a cup so 4 ounces to every full bathtub of water. And sometimes we'll also do dilute acetic acid or household white vinegar soaks, especially when you have the crusting that you see. It can help to debride it a little bit. So the data regarding bleach baths is actually in kids with eczema. It really decreases their bacterial load on their skin, and so that's why I like to use it a lot in other situations where you might be predisposed to infection. And so this picture is of a young man who really had a lot of trouble with infection. Not the kind of infection that landed him in the hospital, but he had to take a lot of antibiotics. And when we started bleach baths, that actually helped quite a bit. And then skin camouflage. So this is really useful for any visible location where perhaps in certain social situations someone might want it covered. It might be a face, it might be an arm, but you can see that you can do some amazing things with these special skin camouflage products. So it's not like regular makeup, and I make sure I tell all the boys that this is not wearing makeup, this is camouflage. So, but you can see the tattoos covered up. You can see the before and afters of many different things that people have been able to cover up nicely. And this is one of my favorite pictures, the next one. This is actually real. And so if you go on their website, it shows him looking like he has no tattoos, and then little by little he washes off body parts and he's completely covered in tattoos. So really very, very amazing. All right. Okay, that's all that I had, so thank you very much for the great opportunity.